So today we are meeting to discuss various forms of tooth resorption, and I'm sure everyone's excited because this is your one-stop, place where you can just quickly review all the various kinds of resorptions, and ADC exam practically has asked most of it, right? So I think it would be a very good opportunity for everyone to get together and discuss all kinds, whether it's trauma related, then whether it's your invasive ones or your infection related or inflammatory types. So there are three broader categories which we are going to discuss today, and underneath those three broader categories will come the individual types based on the etiology and based on the location, sometimes based on what is the effect seen on the, whether it's the resorption kind, whether it's replacement kind. So hi Angie. And so it's a good opportunity, I guess, because we have been thinking about it, we've been talking about it in our live classes, in our internal classes also. Everybody wanted, let's collect information from everywhere. We have put in hot notes also, actually, resorption, but and I've created hot notes as well from for all kinds of resorption at one place. But this is one opportunity where I thought that let's look at the diagrams, let's look at the elaboration. We'll talk about the pathophysiology, we'll talk about the etiology, we'll also talk about the possible treatment plans, because ADC does give every kind of resorption, and at least per examination, ortho related, external cervical, whether it's apical ortho or it's your inflammatory resorptions associated with infected pulp, then trauma related resorptions. I think all kinds of resorptions in the same examination are asked. So this is one place where we'll review all of them, and all your questions will be answered today when you do it as a combined category. The treatment for external cervical resorption is also a lot of the times asked in the exam. So whatever we discuss today, they are high yield concepts. Directly use those concepts to apply to the examination questions, and you will ultimately arrive at the correct answers. The point of doing all these public sessions is that you have your concepts on your fingertips. In the examination, you leave the guesswork out of the equation and out of the room. And what you really have is the solid concept. And when an exam gives you an exact question of that particular concept, you can straightway apply the concept that you're learning here. So it's not just a brief read. Every discussion point gets applied to the examination question. Okay, so first of all, just be in the receiving mode. Try to understand the three broad categories, then the subcategories. In the subcategories, there will be different pathophysiologies, different etiologies, and different managements slightly. Focus on individual resorption, and each resorption, whatever etiology, pathophysiology, and management aspect is, focus on individual aspect. Okay, so I'll cover all the three categories today, subcategories as well, and in the subcategories all the three aspects: pathophysiologies, etiologies, as well as management. So a lot of attention would be required because you would not be able to retain everything out of it, but do give it a next read or a watch for revision if you want to watch again. Otherwise, you can simply go to the hot notes where the summary of this and the notes of these concepts have been added for you to revise. Okay, let's start discussing it. So I'm going to be talking about all the three broader categories, and then I'm going to be talking about individual ones. So I'll take one category at a time. So first of all, we need to learn that the various forms of tooth resorption, what really it means. So tooth resorption is basically when you start losing the tooth structure, both organic as well as inorganic tooth components. We know whether the hard tissues, enamel or cementum or dentine, they're composed of organic component as well as inorganic component. Resorption affects both and not just the organic part or the inorganic part. Completely, the enamel starts resorbing, the dentine starts resorbing, or your cementum starts resorbing. Both the organic and inorganic components start resorbing by the clastic cells. right? So clastic cells are which resorb the hard tissue present in the tooth structure. Now, all these resorptions are classified based on the etiology, which will help you to diagnose it, to find the predisposing factors in the patient's history. Now, a lot of time in the examination, various kinds of resorptions are given, and they may look similar as well. The location will also be similar, but the history will provide you the predisposing factor. And under the diagnosis and management planning cluster, they do ask you what is the predisposing factor. Sometimes more than you, the patient wants to know why this is happening. Does that make complete sense for everyone? That the etiology questions for each kind of resorption is asked, and that sometimes radiographically looks similar, but you will have to identify it from the patient's history. So when you apply the rash concept, this would be what's present in the history. So you're going to use the H component a lot when you're trying to identify the etiology of various resorptions. So first of all, you learn how to classify these resorption types. Then you will learn what is the pathophysiology, what is the basic reason, and pathologically how it progresses, so that your management strategies can be devised and designed around the pathophysiology. What is the causative factor, how it is progressing, what is leading to the progression of this resorption, and how my management and what kind of treatment I can provide to arrest it, right? What is the kind of prognosis, whether it requires extraction, whether it requires endodontic management, or it is does not require any management, requires monitoring. Even when you're doing the management intracanal, what kind of dressing would you give, how long would you give to arrest it, then what kind of final obturating material should be used. All those strategies will be included and will be discussed here today. So this complete class will provide you recognition, diagnosing, and then the treatment planning of all these different kinds of resorptions. So these three different kinds associated are your trauma induced, where there is some kind of force. Trauma is a physical force here. What we are talking about trauma here is the physical trauma, not the chemical trauma here. Okay, so the chemical trauma is the infection induced one, the number 2. So can you differentiate? Because we know biologically the trauma can be chemical or biological as well as it can be physical. But when you say trauma induced, it is your traumatic injuries, the physical injury or pressures, and that's why the subcategories will be discussed. So is that clear? Because if you know what I'm linking it with, you remember that concept we've done at this stage. I'm sure you remember every class and every question that we have discussed. The pyogenic granuloma, the trauma induced, we have learned here. So there we have discussed it could be both physical due to overhangs or due to the chemical bacterial trauma induced by the existing plaque, right? So you know what I mean and where we have discussed that concept before. But in this case, purely we are talking about is the physical trauma. Now the infection induced, which is now the chemical or the bacterial biological trauma, which causes inflammation in the periapical area within the canal also. So infection induced resorption also we'll discuss. Then there would be hyperplastic kinds, which is aggressive and which is invasive, right? So it is an aggressive resorbing tissue invasion by granulation tissue. We are going to be talking about hyperplastic invasive, infection induced, and the trauma induced resorptions. So each category, 3 main categories, also has 2 or 3 different subcategories, which I will be covering individually. Okay. So for the trauma-induced resorption, the first kind is the surface resorption, right? It is, as the name suggests, only on the surface and a very shallow resorption, and most of the times it is self-limiting. And it is slightly resorption of cementum or dentine, which can result from minor trauma. So it can be internal as well. That's why it will begin in dentine when it's internal, and it can be external as well, and that will begin in cementum when it is external. So it can come from some local injury, but The injury has to be minor, and it will lead to only superficial surface, minor, and self-limiting kind of resorption. It can also begin internally, and then the dentine wall will start resorbing. Now, internally usually will not come from the trauma more so. It would come from some minor pulpal irritation, and predominant reason for internal surface resorption, which is trauma induced, comes from occlusal traumas. So you can maybe imagine higher occlusal forces, and sometimes your bleaching as well, where the pulp gets irritated. Again, it is a kind of a physical irritation, a physical trauma, and not the inflammatory or infection kind of resorption. It is usually asymptomatic. Sometimes it is so superficial that even on your x-rays you can miss it. And that is why no treatment is necessary, because the number one important point is it is self-limiting. Does that make sense for everyone? Please form the keynotes here. Trauma-induced first kind surface resorption, very self-limiting, does not require any treatment, often goes undetected on radiographs. Two kinds, internal and external. External can come from local injury like luxation, and internal one comes from your occlusal forces or sometimes bleaching, and that is why no treatment would be required. Now, transient apical internal resorption. So we have done also in other classes transient apical breakdown. Everyone, do you remember? It would be asymptomatic, Aisha, right? Now, anyone remembers in the last class also we had done transient apical breakdown. That is also associated with luxative injuries. And that also I told is a self-limiting resorption. So do not rush into doing RCT with that. So that's a very rare phenomena which allows the healing of the periapical area by ingress of vascular tissue. So because this minor resorption, transient apical internal resorption or external resorption, is basically to allow ingress of a greater vascular network so that vascularity can enter and repair and induce the healing process in the pulp. Does that make complete sense for everyone? Okay. Do not talk about ortho as of now. We are only talking about trauma-induced first kind surface. Do not rush into conclusions here. Meenakshi, is that you? I don't know. Can't see the name. Wait. Yeah, Meenakshi. So don't jump into assumptions right now. Okay, occlusal forces is from your bruxism, could be from your trauma from occlusion, could be your high points. So it is just your occlusal forces on the teeth. Do not come to ortho forces. Ortho forces are different. Occlusal forces are different. When given in the exam as separate options, they mean very different forces. Meenakshi, do not confuse. Okay. Clear for everyone? So yes, surface kinds, self-limiting, transient, and internal and external kinds. And when it is occlusal problem, what can you do? You can just do the occlusal adjustments. That is enough for your management. Clear for everyone? Meenakshi, got it? So when it is occlusion induced, you will check for occlusal adjustments and reduce the mechanical trauma. Okay? And now the transient apical internal resorption, it is associated with some trauma, usually or luxative kind injuries, where there is slight resorption within the apical area, which allows greater vascularity to enter. Okay? And usually there is a spontaneous remission. It resolves on its own as far as and as long as your canal remains uninfected. Your transient apical breakdown does not require any treatment. Tanveer, transient apical breakdown takes place to allow for the healing process of the pulp. Is that clear, Tanveer? After your injury, sometimes there is a body's natural healing response, which is why the name itself says transient. That means again it is self-limiting. That is why it has been put under the category of surface, because all the three kinds in your surface resorption are your self-limiting. Crystal clear for everyone. This is extremely first category completed. Clear for everyone? No treatment. Pathophysiology understood, coming from your trauma, how it shows up on radiograph, how superficially it involves, and the transient apical variation as well. These are the pictures just for your memorization here. See, the mobility here, Sakshi, will be because of the injury, but not because of the resorption per se. Resorption is not leading to the mobility. Mobility, if at all, is coming from the kind of injury that the tooth has sustained. Does that answer your question? Yes, Dua. The transient apical breakdown is a healing mechanism, but the surface resorptions are minor trauma responses. They are not healing mechanism. Dua, can you differentiate? Figure B is your transient apical breakdown, which is the healing mechanism, but the surface one, which is A and B in the picture A, they are your regular response to the trauma, but they're self-limiting, and because the trauma was very minimal. Understood? Luxative injuries only. Clear? Yes? No, Tanveer. Not after every injury, usually luxative injuries, and it is not always seen. Sometimes you can see this response, sometimes not. Yes. Aisha, resorption is so minimal, it doesn't affect the PDL on a long, in a very major manner. That's why it is not the cause of mobility. Okay? So picture wise also, diagrammatic wise, clear? No, it would not be favorable or unfavorable. If it progresses, ultimately it becomes an unfavorable response. Right, Aisha? Or okay. Now let's talk about the second one. Okay, pay attention, please. Now I'm talking about the second one. This is crucial because only 3 weeks are left and there's not a lot of revision time left. I want you to have full focus here. Okay, in the class only, try to grasp as much as you can. The second kind, the trauma induced second kind, again, it's a physical trauma. Now that's coming from your pressure and orthodontic resorption. Okay. Clear, Meenakshi, this is the category that you were talking about. It's a second subcategory within the trauma-induced resorption, which is the pressure and orthodontic resorption. Now, there are two types, okay? Now, other pressure reasons are also there, other than ortho. So, first of all, it is your physiological. Now, physiological ones are the where there is a natural primary tooth root resorption due to the pressure coming from your developing permanent tooth bud. That is your physiological process. Nothing rocket science in that. Everybody understands the physiological pressure resorption, right? Which only happens on the primary teeth due to the erupting permanent teeth. As simple as it can get. The other ones are your pathological, pressure related, pathological etiological resorptions, where the etiology is coming from pathological origin, cysts, tumors, or which are expansile in nature, which generate physical forces. Now, everyone has done that in the Odell case ameloblastoma. You have done in Megamaster file, Ultimate Advanced file, SBQs on that. Associated with the ameloblastoma and resorptions of 4/7, 3/7, like your mandibular molars. Everybody remembers that? So now that is your pathological resorption. Pressure related resorption of pathological etiology. Clear? So pressure related is physiological in primary teeth, pathological coming from impacted teeth, tumors and cysts. We have seen questions like that. Impacted canines absolutely can lead to the resorption of associated permanent teeth, which is pathological, right? And then the third kind of pressure comes from your orthodontic forces. Now, orthodontic can also induce a cervical kind, but that is not put under the category of pressure. Okay? Everyone, the cervical, the external cervical resorption associated with orthodontic treatment is not put under the pressure. That is an invasive and a hyperplastic kind that would be under the third category. I will cover that one in the third category of hyperplastic kind, cervical kind. This pressure-related orthodontic resorption, which we are talking about here, is only with your apical area of the root. Distinctly segregate these two concepts in your brain, everyone. If you're given an OPG and you see blunted roots apically, that's your pressure or orthodontic induced, trauma induced resorption. Clear? Now, there is another case that can be given in your OPG or in your IOPS in certain teeth, especially anteriors. You will see cervical resorption and the history of ortho treatment. That is orthodontically induced external cervical resorption. That's not pressure or orthodontic resorption. Everyone here segregated these two resorptions and concepts in your head. I will talk about external cervical resorption when we come to the hyperplastic kind, just giving you an overview so that you don't start confusing it right away. We have an exam question, Saida. We have external cervical resorption associated with ortho also. Those questions also come. Yes, Kinza, ortho can cause two, but the most common one associated with ortho is on the apical area of the root, which is under the pressure kind, trauma-induced pressure-related resorption. First is Kinza due to pressure from the ortho. Okay, then the second kind from ortho is the external cervical. That is a hyperplastic, aggressive, invasive kind of resorption. Pathophysiology is slightly different there. The mechanism is slightly different there. That's why it's put under the separate category, Kinza. But yes, when the question is asked, what is the predisposing factor or what is the etiological factor? Then for both you will choose orthodontics based on the history of the patient. Right, Kinza? Again, rash will still apply. The history has to include ortho treatment. Okay? There are other predisposing factors as well for the external cervical resorptions, which I will talk about it when we come to that. So far, so good, everyone. So let's focus on the pressure-related ortho, which is seen on the apical root resorption, and it comes because of the tooth movement and the forces that were applied during the ortho treatment. Clear? So mostly these factors that affect in the orthodontic resorptions are age and the morphology of the teeth. They are also involved, but the most important is the magnitude and direction of the orthodontic forces. So now if you get in exam the question, what is the factor that is responsible for this orthodontic resorption? Whether it's time, whether it's age, whether it's the tooth morphology or the magnitude and direction of the forces. The most important factor is magnitude and the direction of forces. Okay. So usually for the orthoresorptions also, there will be no signs or symptoms unless it is so much and the forces were so uncontrolled and excessive, the mobility can be seen. Everyone knows, right? With abnormal, excessive, persistent orthodontic forces, mobility can be induced because the overall the PDL gets affected, right? In ortho, overall the PDL is affected, and if the forces are not intermittent and also not controlled and within limits, it can lead to mobility, right? So that's why excessive resorption and mobility can happen if excessive forces are used. Now, when you see that excessive, more than normal resorption is happening, then the cessation of orthodontic treatment for at least 6 months. And then once you stop the treatment, resorption will cease. That is the management. So for your, suppose an exam, you're given an OPG and apical resorption is way above the optimum, right? More than the apical third or even not even apical third. I think even half of the apical third should be involved. But if more than that is going, more than apical third is involved, then the treatment and management has to be that the orthodontist has to cease the orthodontic treatment at least for 6 months for it to stabilize and arrest. But it will arrest immediately once the movement stops. But to stabilize, it will take 6 months. Is that clear for everyone? Could you please receive the concepts first? I'm not looking at the questions because there are so many concepts that I'm delivering. If you don't receive them and just forming your questions, you're missing out on so many points right now. So management is extremely important. You pause the ortho forces for 6 months minimum. It's crucial. It is an exact exam question. And then when it stops, does it stop after 6 months? No, it stops immediately, but it takes 6 months for it to stabilize. And you can restart your treatment at least after 6 months. So that is the minimum period to stop. That is normal, Nimra. That is an acceptable amount, right? So this is your second category, pressure and ortho related. Again, crystal clear, everyone. The first kind was surface. Second is pressure and orthodontics, which includes physiological, pathological, and orthodontic. The first one, surface, included internal, external, and transient apical. Clear for everyone? So main category, into which the second one also we have completed now. Let's look at the pictures here. So first one here is the physiological one where the primary tooth is putting the forces on the developing permanent, permanent is putting the forces on the primary tooth. Then this is the pathological kind where the expansile tumor or cyst or a neoplasm is putting extensive forces on the adjacent teeth, leading to the resorptive forces and external kind of resorption. Then this is the ortho-related pressure associated apical blunting in the apical area. And the history would present ortho treatment. In this case, pathological, you will find either an impacted tooth or a tumor or a cyst. And in the physiological one of primary tooth, you will definitely be able to tell with the history, the age, the presence of primary teeth and the developing permanent teeth, right? All three kinds are different, clear for everyone? Perfect. Let's do the third kind now. Now, which is your replacement resorption associated with trauma. Again, two types, external and internal. Okay, so the external one, the root gets replaced by bone due to pedial necrosis and ankylosis. The clinical signs will be high percussion sound, no mobility. On radiograph, you will see the obliterated PDL space. And prevention is prevent avulsion. Most of all, what is linked with the replacement resorption? Number one reason is the avulsion. Clear? So trauma-induced replacement resorption comes from avulsion. So prevention comes from use of mouth guards during playing sports. And in growing patients, the management is, suppose in a growing patient, you have noticed after reimplanting an avulsed tooth, the replacement resorption occurred. To maintain the bone height and to prevent the infra-occlusion and the lack of bone growth, to prevent that, the management will become decoronation, right? In the growing patients, decoronation would be appropriate. You can also avoid these kinds of resorption in the first place when the avulsion happens. Do the timely reimplantation. So time is the critical factor to prevent it, right? Because the condition of the PDL cells is dependent upon the time out of the mouth and also on the storage media in which the tooth was kept. So storage media, time outside the mouth, correct handling of the tooth will assure that your replacement resorption does not occur. Okay. In certain developing dentitions, in mixed dentitions, when the child was like in the mid, early adolescent age, sometimes you can see when you have reimplanted it in a developing dentition that if the tooth becomes ankylosed, it can lead to lack of the bone growth. To prevent that, decoronation is done, right? Which promotes the ongoing alveolar growth above the crown of the or above the root of the tooth. Because if you try to extract the whole root because of ankylosis, it will lead to severe bone loss. Does that make sense? Dua? Why you're doing decoronation? So you will remove the crown, root will remain embedded, bone will then continue to grow with it, right? and the tooth will not remain infra-occluded. And then temporarily, while the child is young, you can replace it with your resin reinforced Maryland kind of bridge. In younger patients, because that's minimally invasive, mostly depends upon the bonding on the adjacent teeth. Removable is not favorable, implant is not favorable at this age. So a minimally invasive resin retained bridge would be the preferred replacement. Is your question answered? Now there is another kind of replacement resorption which is seen internally. The first one is clear for everyone, associated with avulsion. What are the signs? How you can prevent it? What will you do when you see it in growing patients? What part you could not, Suchitra? I need a proper question to answer that. So now there is another kind which is internal replacement resorption. Now here the bone replaces the pulp space which is seen post-trauma. Decoronation part is where when you have identified and diagnosed ankylosis, Suchitra, Smita, that once you have Sneha, once you have diagnosed the ankylosis, you've seen it has become obliterated. Now the tooth is not going to grow, right? It is not going to erupt anymore. Is that right? So there is not going to be an eruptive bone formation, and tooth will remain infra-occluded, adjacent teeth will grow, and that leads to bone growth also is hampered. So when the pubertal growth spurt period comes, right, there is a pubertal growth spurt that happens, right? We have done that 11 to 12, 12 to 14 in boys and girls. We have done the pubertal growth period which comes. Ankylosed tooth can challenge. If the crown remains, bone will not grow there. But if you remove the crown and keep the root embedded, then the bone will overgrow that root space. But bone cannot overgrow the infra-erupted crown. Does that make sense? The bone cannot overgrow an infra-occluded crown, but if you decoronate it and leave the root embedded, the bone can grow above the root, but it cannot grow above the infra-occluded crown. Now, does that make sense in your imagination? Bone cannot come over the crown, but bone can grow over the root because the pubertal growth spurt is coming. Maxilla will grow, mandible will grow, right? And usually with avulsion, your maxillary teeth get affected. If your crown was there, bone will not able to, crawl up on it. But if you remove the crown and then, put the gingival and suture it, and then the root remains embedded, then bone can overgrow the root. Understood? Everybody clear? Perfect. Now you know the decoronation, and it must be done before the pubertal growth spurt. Yes? Is that right as well? It should be done before the pubertal growth spurt to utilize the ongoing alveolar growth phenomenon. Okay? Now let's talk about the internal replacement resorption. It's a rare condition where the replacement of tooth structure with bone is initiated within the root canal system. It will be seen within the root canal system. Missing tooth would be replaced, Nidhi, while the child is young by minimally invasive resin restored FPD, right? Or like your every spoon denture, but that's not so comfortable for the patient to maintain as well. So usually minimally invasive resin restored Maryland kind of bridge. And once the child is completely adult, then if it's a single tooth, you can go with the conventional FPD or implants based on the patient's choice. Okay, so usually this internal replacement resorption is considered as a metaplasia occurring in the normal pulp following a traumatic episode leading to the production of bone-like tissues within the root. So again, for your internal replacement resorption also, the possible etiology is still trauma, but a minor grade 1, which induces bone-like tissue formation within the root. Clear for everyone? Nikita, you would have done the endo treatment in an avulsed tooth within the first week of the treatment. You won't wait till ankylosis for that, Nikita. Okay, come back to the attention, please. Center of point is internal replacement resorption. You guys are missing out. Decoronation is clear now. Now this is the external replacement resorption, where now this anything outside this red line would be bone. And here, this zigzag red line means that all this space between these two red lines is obliterated by bone-like structure. So in external one, it would be from the external surface of the root, and it would happen in a zigzag pattern, like uneven scalloped pattern. Internally also, you would see it like a scalloped pattern, and both spaces are obliterated by bone. That is why, by definition, they are replacement resorption. Yes, Kiza, first of all, pictures clear? I'm going to take you to the previous slide. Pictures clear, Kiza, everyone, for both external and internal. Both will be obliterated by bone, radiopaque structure. Okay, Kiza. Yes, Taranum, it would be difficult, but in the growing stage, removal of the bone would be detrimental, or in the adulthood, when the entire bone has formed, that would be detrimental, Taranum. Growing period, it would be more detrimental, right? That is why this is not the right age to remove it. And it has ankylosed. Someday or the other, you will remove it, bone loss will occur. So better to do it when the child has attained the full bone growth, right? Perfect. All the three subcategories clearly understood from the first trauma-induced kind, the surface one, the pressure, and then your replacement kind. Now comes your infection type. So infection type is associated with two subcategories, internal and external. Very simple, no complexity here. The reason here in both the things is one etiology, which is root canal, which is infected, right? And when your predentine gets damaged because of that infection, it exposes the dentine to the odontoclastic activity, which leads to the resorption. So predentine has to be damaged and disrupted. Only then the odontoclasts become active and start resorbing dentine. That's your like first year, second year kind of concept. Exam is not asking it, just for your information, that when the predentine gets disrupted, then the odontoglass starts resorbing dentine within the canal system. So it initiates inside root canal due to infection, that is internal inflammatory resorption. And if clinically it is seen in the coronal portion, then you will find a pink spot clinically. But if it is happening within the radicular area and not around the coronal area, then there will be no symptom of it. You can sometimes have dull pain, mostly symptom free also. And sometimes it can become and progress so much, go to the external surface and become a draining sinus tract. Clear for everyone. Possible symptoms, usually asymptomatic. Dull, mild pain can also be seen. When present coronally, pink spot can also be seen. Radiographically, you will find a round, symmetrical radiolucency within the canal. Now, clinically, sometimes when it is too extensive and has made an external connection with PDL and the soft tissues, then you can see a sinus tract also associated with it. Please give me a big heads up if it's so far making all the sense to you. I'm trying to go as slow and explanatory as possible for individual resorption. My intention is that you learn majority of it right away in the same class. Now, management of your internal inflammatory resorption is removal of the infective agent. In this case, it would be your infected pulp. So the instrumentation would be very crucial when you have internal resorption. That is why when you have these cases in exam, choose the option of referral, because the instrumentation is not standard instrumentation here, because your instrumentation has to debride the biofilm of the concave walls. So the access to the areas is very difficult, and sometimes you have to consider that there should be no remaining tissue, debris, smear layer on these concavities. So you have to do adjunctive measures. Your file system alone will not be enough. Does that make sense for everyone? That is why this immediately goes to the higher difficulty of endodontics and immediate specialist referral. You will not attempt it in the clinic yourself as a general dentist. So that is direct answer to your question. Make sense? Now, what are some of the adjunctive measures? Although beyond the scope of ADC exam because it's a specialist thing, but there are something known as agents like canal brush, ultrasonic irrigant agitation, or using hydrogen peroxide, alternating it with sodium hypochlorite irrigant to produce an effervescence which mechanically disturbs the biofilm on the walls of these defects. So either canal brush, ultrasonic irrigant agitation, or effervescence due to nascent oxygen production by using hydrogen peroxide, alternating it with the sodium hypochlorite. Make sense? All the three adjunctive methods are clear. Canal brush, ultrasonic agitation, or alternating hydrogen peroxide with your sodium hypochlorite. Now, after cleaning the canals completely, you must give inter-appointment calcium hydroxide medicament as well, because it will also make sure to arrest the further resorptive response. Okay. Now, apical root filling should be performed and the resorptive defect should be filled with your thermoplasticized GP. Your conventional GPs will not work here. Thermoplasticized GP has to be used. And when the perforation has occurred with the external surface or the defect is too large, then even MTA should be considered, because thermoplasticized GP will not strengthen the root, but MTA will integrate with the root and will increase the strength and integrity, preventing the fracture. Clear for everyone? If the defect is large or there is a perforation with the external root surface, then MTA should be used instead of thermoplasticized GP. Understood? Now, prognosis in this case depends upon the remaining tooth structure. Because of the loss of tooth structure, if there is reduced structural integrity, this tooth can fracture. So, prognosis is dependent upon the remaining tooth structure and the structural integrity of the root. Clear for everyone? Yes or no, please? If so far, it's all making sense. So fill the defect with GP or MTA. Everyone understood when MTA? When it's perforated or the defect is extremely large. Now this is the picture of internal inflammatory resorption, and the etiology is, this is the inflammatory kind, 1 to 1.5% intraorally in the canal for the safety of the periapical tissues. Sakshi. Right? Infected pulp coronally, vital pulp apically sometimes can be also seen, and the resorption can lie in between. That's one of the possible, but you cannot predict what route it will take. But this is how the circular radiolucency will look like. And the etiology is infected canal, infected pulp, right? Which is stimulating the odontoclastic activity. Right? So the odontoclasts are coming from the vital pulp here. Second kind of infection-induced resorption is external inflammatory resorption. Same reason, same etiology, infected pulp. Instead of getting resorption internally, it would happen on the root surface. Surrounding tissues like PDL and bone will also get resorbed here. Root, surrounding bone, both will show this kind of resorption, right? There will be some kind of cementum damage. Again, there has to be some redentine damage and some cementum damage to induce inflammatory resorption. Whether internally, then predentine has to get damaged, and for externally, some cementum has to get damaged because of your necrotic pulp, right? So similar to inflammatory one, that there has to be some damage, some previous damage to expose the root surface to your resorptive cells. Okay. So there could be like some pre-existing history of injury that had already exposed the cementum and damaged it. So when the pulp got infected, it started resorbing. That is why this external inflammatory resorption is most commonly seen with pulp which gets infected after trauma. Does that give you a concept here? Imagine the etiology is infection, but the cementum needs to be damaged. That is why the injury has to be associated to damage the cementum. And then the pulp got infected, and then external inflammatory resorption began. Understood? So the most common finding, clinical presentation of external replacement resorption, external inflammatory resorption, yes, will be associated with traumatized tooth where the pulp became infected, not non-vital, Charmy. Not every non-vital pulp is infected, Charmy. Very slight nuance, but a very important difference. Okay? So, due to the presence of necrotic infected pulp, teeth with external inflammatory resorptions will be infected, will be non-vital. Due to infection, they will become non-vital, and that's why there will be no response to the pulp sensibility testing. Because this resorption completely depends on the infection. Without infection, this external inflammatory resorption will not begin. Because trauma-induced resorption was only surface level ibadat and self-limiting. But when it gets infected, it becomes an inflammatory resorption and it becomes more severe in nature ibadat. Good question, but trauma one was very surface, self-limiting, asymptomatic, barely noticed on the radiograph. Remember, Ibadat? Trauma induced was surface only, external. Or replacement, right? This is trauma when it got accompanied by infection. That is why it comes under the category of infection induced resorption. It is not trauma induced directly. Right, Ibadat? Understood? That is why it changed its category. The Yes, the trauma has to be present in the history, but the pulp has to get infected to lead to the external inflammatory resorption. Very good link, very good concept, a little bit complex, but you will get there when you pay attention that if it's just trauma, it will limit to the surface, but if it gets infected, it will become external inflammatory and it will change the category. Understood, everyone? Yes, Tanveer. So now, because it happens because of the infection, the management aim most importantly is to remove the infected pulp. It is really wonderful, Rajwant, when especially when you look at this, basically the presentation here and the three categories and then the subcategories and every single reason, it has become so simplified, right? Kaylee, complicated crown if the root sustained any trauma, right? Even without luxation, if the root did sustain any pressure and trauma, and then depends. Then, if it's just trauma, it can lead to surface level. If the crown got infected, then it can become an external inflammatory resorption, right, Kaylee? Again, the method is simple, the equation is simple. If it's just trauma, usually it will remain to surface, but when it gets infected, it will become an infection-induced resorption, becomes the inflammatory resorption. Yes, Tanveer, yes to your question as well. Now let's talk about management because here the source is infection. So remove the bacteria, remove the infected pulp from the canal system through your endodontic treatment, as the root canal infection in the presence of cemental damage frequently can lead to external resorption. That is why you must start it within the 10 to 14 days of reimplantation following tooth avulsion. Because in avulsion, there is an absolute damage to the cementum, predicted damage. That's why external inflammatory resorption frequency is again higher in your avulsion, right? Most associated, what kind of injury it is associated with avulsion, because there the damage of the cementum is most likely occurred. And that is why the guidelines recommend either to start immediately RCT or within the week. Agreed? Because they know that it has disrupted, the cementum damage has occurred, and root canal infection is also highly likely, so induce and perform the immediate RCT. Understood now? Cementum has disturbed, infection is very likely, so that is why remove the pulp immediately or within a week in your avulsion, because combination of trauma and infection will lead to external inflammatory resorption, which is highly present in an avulsion situation. In other sources of injuries where there is no avulsion, you may or may not have cementum damage. That's why you wait for the signs till you do it, right? Agreed or not? Either you wait for the signs of infection or you wait for the signs of resorption, whichever comes first. Agreed or not? In other kinds of injuries where the cementum damage is not confirmed, you wait for the signs. But in avulsion, you almost know that cementum has damaged, so you have to immediately perform it. So let's look at the image here. This is your external inflammatory resorption. It can be present apically, it can be present laterally. There has to be history of injury, trauma, and the pulp has to be infected. Okay? So it can occur on both these surfaces, lateral or apical, wherever your cementum is damaged and wherever the infected pulp gets channeled to the external root surface area. Through the lateral canal also it can happen, through the apical area also it can happen. Now the third kind, which is your hyperplastic invasive category. So hyperplastic invasive also has two types. So your first one had three types, right? Your first one had three types. Is that right? Trauma induced has three types: surface, pressure, and replacement. The second category was infection induced, which had two categories, which is internal inflammatory and external inflammatory due to infected pulp. Now, this is your third broader category, which has two types. One is cervical and the other is your coronal invasive. Okay, so last two ones left. You've held so good so far. Please maintain this attention and you will learn these two as well. So the cervical invasive resorption is basically invasion kind of destructive resorption in the cervical area. It starts at the CEJ. It is progressive, it is aggressive, it is resorptive tissue that is formed and it invades the heart tissue. So it's kind of coming from externally, leading to the progressive replacement of mineralized tooth structure by the granulation tissue. It's hyperplastic, so granulation tissue is formed. And when the heart structure is resorbed, that gets filled in by the granulation tissue. Etiology is kind of unknown, but the known some factors which have been associated and suggested are that there has to be some damage in the CEJ, either coming from your trauma, parafunctional habits, occlusal forces, or orthodontics. These are most important causes, and one of the other is your bleaching as well, internal bleaching. Is that right? So internal bleaching, dental trauma, parafunctional habits, occlusal forces, and orthodontics, they have been highly linked with these external cervical resorption. It happens externally and the granulation tissue proliferates. So clear for everyone? There is a fibrovascular kind of granulation tissue that occurs at the CEJ region, and it invades the heart tissue, and it has some dense inflammatory tissue and connective tissue in it, and the entire resorption cavity gets filled by that. Understood? So what kind of tissue you will see if you raise the flap? What kind of tissue will be filling your defect? Does that make sense? Right? So the signs can be, well, the diagnosis can begin with the history. Radiographically, you will see the resorptive spot on the radiographs, right? Clinically, it can also have a pink spot in the cervical area, which is because your granulation tissue, which is highly vascular, is reflecting through the enamel. Got this, everybody? External cervical resorption will also and can also look like a pink spot reflecting underneath your enamel. It is usually asymptomatic, but if it has communicated with the canal internally and there is contamination from the external environment and the pulp has become inflamed, then the pulpal symptoms can develop if it has infiltrated within the canal deeply. Clear for everyone? Initially asymptomatic, once it communicates with the pulp and the external saliva and bacterial agents get into the pulp, it can become your pulpal symptoms can develop. Usually your conventional radiographs have been used so far, but recently your CBCT has also been used and utilized to get the complete extent of the resorption to define the prognosis and plan the treatment, because we are going to talk about the classification of these defects. These defects have different management approaches. Examination has already asked you these defects, you know that? Exam questions, ultimate advanced file, MegaMaster includes these questions. Exam is already asking you questions on these. And based on the radiographic size of your defect, you are going to answer the management plan. Are you ready to learn based on the size, the treatment, how it changes? There is external approach, there is internal approach, and then the extraction approach. So we are going to talk about it. Overall, the attempt of the treatment should be to removal of the resorptive tissue. This granulation tissue has to be removed, right? Whenever the tooth is savable, your main agenda is to remove this granulation tissue. Now, this is the diagrammatic representation. The entry point was CEJ. The heart tissue start getting your osteoclastic activity. Resorption occurs and the defect gets filled by that granulation, hyperplastic, highly vascular and connective tissue. This is what it is getting filled with. Clear for everyone, right? So replacement one has bone, internal inflammatory, there is still pulp within the canal. But here it would be your actual granulation hyperplastic tissue. That is why this is a third separate category of hyperplastic invasive resorption. I'm sure they are in the hot notes about it. Just check and let me know. Yes? Yeah, they are quick for your immediate revisions. Now comes your cervical resorptions classification. Okay? Let's look at it. There are various defect categories. There are 4 classifications. There is a small kind near the cervical area, just within the dentine. Then the second class is, it's a well-defined, penetrated close to the coronal pulp chamber, shows little or no extension into the radicular dentine. So it has kind of like reached full thickness of the, wait, yeah, I'll just do that. Meenakshi, wait. Yeah, that's clear now. So first kind is the small invasive lesion just within the dentine. The second type is which has completely gotten into the dentine, but not gotten into the radicular one, still is in the crown portion only. Can you appreciate that? So first and second class only differ in the size but still remains within the confine of the crown. The third class is where it has gone into the radicular dentine, going into the cervical third of the root. And the fourth category is which has gone beyond the coronal third of the root and almost involving the entire root. Can you see all the four types now? Yeah. Give me a yes so I can switch the slide and move to the next one so that you have fully visualized the four classes. The management question, Minakshi, already asked in the exam. Already asked. External cervical resorption question, already asked in the exam. Now, based on the classification, you will answer changes with each types. Classification is not asked, Tanveer, but if it is asked, it is good to know now, na? Now you can answer if you see a small spot, it's class 1. If it's complete thickness of root into the crown, class 2. If it's slightly started to reach the crown, your radicular root, dentine, then it's class 3. Completely into the root, it's class 4. It's very simple classification. When you memorize these diagrams, you will easily look at the resorption on the X-ray and can answer this, right? So now this is the classification of your cervical invasive resorption. When the defect is very small, say your type 1, class 1 and 2, or a buccal or lingual located resorption defect, which is easily accessible by raising a flap. Agreed? If it's class 1 or class 2 or present buccally or lingually, you can easily access it, right? By raising a flap? Yes or no's, please. Start visualizing. You're doing the surgery. So you're treating this defect if it's class 1 or if it's class 2, that would be in the crown, or if it's buccal or lingual, you will do an external approach. If the defect is larger, or proximally located. So in your class 3 or proximal defect, you will do an internal approach through the root canal system. After gaining access, you will remove the resorptive tissue by applying topical application of aqueous trichloroacetic acid to induce coagulation necrosis, followed by curettage and orthograde endodontic treatment where necessary. So you can remove these granulative tissues in larger ones because the root is involved. Internal approach is done. So in class 3, internal approach. In class 1 and 2, external approach. And class 1, the prognosis is so poor and hopeless, it is extracted or left untreated if it is asymptomatic and patient wants to save the tooth for as long as can remain. Understood or not? Class 1 and 2, buccal or lingual, by flap external approach. Class 3, because most of the root is involved, internal approach. Class 4, hopeless prognosis, extraction, or no treatment if it is asymptomatic and save the tooth as long as it can sustain. Clear for everyone? Based on the classification, approaches are clear or not? Class 1, 2, buccal lingual external approach, class 3 internal approach, and class 4 extraction. Or if the patient doesn't want to immediately extract it, leave untreated. It will ultimately exfoliate when no root will remain. Clear for everyone or not? And whether you're doing external approach or internal approach, the tissue is removed by use of 90% aqueous trichloroacetic acid to coagulate, to create coagulation necrosis, then curate it. And then if you're doing externally and pulp is not involved and healthy, then you will not do endo. But if it is internal approach, then you will do endodontic treatment. And if it's external approach, but pulp is also involved, then you will do endodontics as well. So endodontics you will do in external only when pulp is involved. Otherwise, just trichloroacetic acid and your curettage. Simple. And the defect will be filled by your MTA. Yes, the defect will be filled by MTA. Whether intracanal or extracanal, it will be filled by your MTA. Now comes the second types and the last kind of your hyperplastic coronal invasive resorption. It occurs in erupting teeth in the crown portion and it's an enamel defect. It was initially called occult or pre-eruptive caries, but that's a misdiagnosis. Till the tooth is not erupted, pre-eruptive caries cannot happen. It was previously historically believed a pre-eruptive caries, but this was later understood to be a coronal invasive resorptive defect. It's a pre-eruptive resorption. It develops in the erupting teeth and it is characterized by invasion of same fibrovascular granulation tissue but in the localized coronal enamel defect. Instead of CEJ, it happens within the enamel. It was earlier called occult caries, pre-eruptive caries, and in the field of pediatric dentistry, it was diagnosed, but it's a misnomer, and ideally and actually, it is a coronal invasive resorption. Clinically, when they erupt, you will see a pink spot. And radiographically, the margins of the resorptive defects will be irregular. Management again here is also curettage to remove this granulation tissue, make it inactive, stop the resorptive effect, and then provide the restoration. If the pulp is involved, endodontic treatment automatically becomes needed. Understood or not? Same trichloroacetic acid coagulation, curettage, restore the defect if it's within the enamel and dentine, and if endodontics if the pulp is involved. Very simple, complex treatment, but simple understanding. Yes or no, please? So far, so good. Everything is crystal clear. All your resorption is like a hot knife through the butter now. Is it or is it not? It happens mostly in the unerupted permanent teeth, Amrit. This is your coronal invasive resorption. This is your permanent tooth within the enamel and dentine. Odontoclasts lead to the resorption and it gets filled by your granulation fibrovascular tissue. When upon eruption you're treating it, you will use the trichloroacetic acid, lead to the coagulation necrosis, curette it, seal the defect with a perfect final restoration. And if it is approaching the pulp, do an RCT as required. Now this is the summary table if you want to quickly see what we have done so far and quickly review and revise. So for your visualization, the three broad categories are trauma, infection, and hyperplastic. Trauma has three subcategories, infection has two subcategories, and hyperplastic has two subcategories. Let me zoom it a bit. Is this better? Is this better reading? Trauma-induced, infection-induced, and hyperplastic invasive. Trauma has surface, pressure and orthodontics, and replacement kind. Surface is seen with vital pulp and normal PDL. It is mostly self-limiting, treatment is not required, and prognosis is excellent. Then your pressure kind can be because of your physiological pressure, or could be because of pathological pressure, or because of your orthodontics pressure. You have to remove the cause in orthodontics, 6 months cessation, in neoplasm and cyst or impacted teeth, remove that. In physiological, you don't need to manage it. The tooth will exfoliate on its own. Prognosis is usually excellent because upon cessation of ortho treatment, it arrests. Upon removal of cyst and tumor, it completely arrests. Clear for everyone? for the trauma induced. Then becomes your replacement, which is associated with avulsion or other trauma. Internal and external, both kinds of replacements are seen. And usually no treatment is required. Prognosis is poor, especially when the ankylosis is affecting growing jaw and infraocclusion can occur, then decoronation and all that management. That's clear as well. Now comes your infection type, which is inflammatory and external inflammatory and internal inflammatory, which is again associated with infected pulp. Internal one can be seen as pink spot and a central symmetrical radiolucency. External one could be trauma and infected pulp, bowl-like radiolucency in the root and adjacent bone. Treatment is orthograde endodontics. Prognosis is excellent. As soon as you remove the infected pulp, external inflammatory resorption ceases to be. That is why after any trauma, you must continue to monitor for the signs of external inflammatory resorption because you can easily save it. Excellent prognosis. Then comes your hyperplastic invasive, cervical and coronal, pink spot in cervical, pink spot in coronal as well. Cervically has a radiographic mottling, tunneling, penetrate with or without penetration, depending upon which class. Coronal is seen on the enamel, irregular defect within the enamel. Coronal is seen in the unerupted teeth. Prognosis is so far good, but because it's a new tooth and already going for your, restoration, so it's not an excellent prognosis. Completely newly erupted tooth, already going for, a restoration, it is challenged, so it's not entirely excellent and not poor or hopeless also. It's good to fair. Whereas in your cervical one, depending upon the class 1 and 2 will have good prognosis, class 3 has fair prognosis, and class 4 has hopeless prognosis. Class 1 and 2 will require external approach, class 3 will require internal approach, and class 4 will require extraction. 1, 2, and 3, both your internal and external approach are treated by your trichloroacetic acid, 90% aqueous solution, leads to coagulation necrosis, curated, and then do endodontics if needed at all. So that summarizes the entirety of all the possible dental resorptions. I hope that gave you much joy as it did to me, because what a joy it is, right? To have that combined 10-page accumulated information with so descriptive diagrams, such precise notes. Yes, Priyanka, because reading on your own can get confusing sometimes, especially when you're not paying attention to words which create very subtle differences. Thank you so much, Harparul. Thank you, Chapa. I have few announcements, guys, before you leave. Very important announcements coming up. 4 more mocks are getting released, absolutely new. The Pioneer mock is absolutely almost ready. We are going to be releasing it tomorrow for our internal candidates. So those who want to join us just for our mocks, because we have more than 156 mocks in our course. So anyone who's taking the September exam and still want to join us for the mocks, please, we have some windows open. You can join us. And we are releasing a Pioneer mock with all the latest DHSV links, DHSV references, the asylum seekers, the mobile dentistry, the fly in, the fly out dentistry, the remote reach out programs, all kinds of latest professionalism topics are covered. The links will also be provided to you for your deeper understanding and deeper learning. Explanation of the mocks will also be provided to you with the answers and the feedbacks. So Pioneer mock is coming tomorrow. Then all the ADA policies that you've done so far, we have created some about 25 SBQs. That is almost 125 questions from all the 70 policies that we have. So from individual policies, we've tried to create at least 2 questions per policy, which are the most crucial takeaway points. And those have been created as SBQs. So 3 ADA policies mocks are also getting released. If you're looking for March 26 course, then this is the place where you need to be with the maximum mock exposure, because we are doing the maximum number of mock in our course 156 mocks. So that's like in 22 weeks, if you're doing 156, that's close to what? 7 to 8. Every day there is a mock and more. So the maximum mock exposure, and you have 2 months free access available if you join for the March 26 program. You get absolutely the month of August and the month of September at no extra cost. So you just pay for one course and you get 2 months access free. And for our already enrolled candidates, the Pioneer mocks and ADA policies mocks are coming. Yes, Sakshi, I know there are so many mocks. You really have to get more time. But me and tutors, we were discussing, our batch really did get amazing scores on your grand mock. So I want to congratulate you all. You really did score amazing on your grand mocks. That goes out to show the very amount of effort that you have put in, the level of preparation that you're doing. So it goes out to say a lot about the potential of this batch, and I'm super excited to see the examination days and then the results, of course. But yes, but then we thought that, we don't want you to get complacent and think that, oh, I did grand mock and I scored so high. So we don't want you to get overconfident as well. So just to balance it out, we thought, let's give you some real challenging mocks, some new mocks. So we created these Pioneer mocks and these ADA policy mocks for you all to attempt. So one would be released tomorrow, which is the Pioneer mock, and ADA policies will be in 3 parts. So those will be released together on Friday. So yeah, so that's coming up, and the March course is there. If you are still thinking of joining, this is the time. Utilize the maximum amount of mocks that you can get and the maximum amount of classes, webinars, hot notes, mind maps. It is a journey altogether when you start learning on the Winspurt app. All the students' feedback that I receive is that it takes you on a journey. And like today's class, we try to create sessions, we try to create a class where you can just get together, we all get together and take one topic and just, dissect it one step at a time, and it becomes so simplified. The information becomes easier to grasp. So thank you so much. Aisha, I'm so glad that now the resorption is clear. Now, if you close your eyes, you can even imagine all the 3 broad categories and then 3 subcategories there and the 2 in the middle and the 2 in the hyperplastic kinds. I think it's a beautiful summary and yet elaborative, although. So you can take any resorption. You might feel that we covered all of it in a 1.5 hour, but you must know that when you close your eyes for individual resorption now, you know the etiology, you know the pathophysiology, you know the diagnostic signs, you know the clinical signs, and then you know the management. So any resorption, so we practically did how many? Like 1, 2, 3, 7 resorptions we did today, right? In about 1.5 hour. Now, out of these, any single one comes in exam. You know the information gathering cluster question answer, you know the diagnosis and management planning answer, you know the treatment and evaluation answer, right? Yes, you have, Raman, the hot notes for the same. They are available, already uploaded. Okay. All right, so thank you so much, guys. I'll see you on Thursday, Tanveer. Thursday, we are covering for our September batch the sample questions that we are covering. So Thursday and Saturday also we are meeting. We have an extra class on Saturday as well internally. So Thursday and Saturday, we will finish the sample questions which were not covered in the Ultimate Advanced file. So that's the plan for Thursday and Saturday. So thank you so much, guys. It was wonderful having you all. Have a great evening ahead. Thank you so much, Nimra. And yeah, I'm more than happy, and pleasure is all mine. Thank you, Sausan. Thank you, Vidya, Kinjal. Thank you, Aisha. Thanks, Saida. Thank you, Niharika. I'm so glad you enjoyed it. No, we did the 7 pages, Tanveer, in the last class, right? So we are going, it's a 22-page file. So we are going to do the second part of that file, and then Saturday we'll finish that file. Thank you, Meenakshi. Thank you, Ibadat. Thank you, Ibadat. Thank you so much. Thank you, Midhu. I'm so glad. Thank you, Tanveer. I'm so glad you enjoyed the lecture. Thank you. I'll see you guys on Thursday internally and then on Saturday. Have a great week. Continue learning and let's continue to simplify the concepts. Thank you, Raman. I'll see you guys. Bye bye.